Welcome to Skin Sync, the official podcast of Elevate-Derm Alliance, your trusted source for the latest in dermatology for PAs and NPs. Join our hosts for real clinician perspectives and expert guest insights as they explore everyday dermatology topics with practical takeaways.
Hi, everyone, and welcome back to the Skin Sync podcast. This is Buchi Neita, and I am so excited today. I say that all the time, but I'm especially excited today to be here with a very good friend, a colleague, Mrs. Lisa Weiss. She is a physician assistant with Goodman Dermatology. She has been practicing since 2014. She is the former president of the Georgia Dermatology Physician Assistants, and she is currently the medical director of the Rapids Dermatology Conference and advisory board member for Elevate-Derm Alliance. Again, she's a friend, she's a colleague, and she is also our resident expert on chronic hand eczema, which we'll talk about today. So, Lisa, welcome to the podcast.
Thank you. I'm so excited to be here. Thank you so much for having me.
Thank you. I'm very excited. So let's kind of dig right in. So you have been kind of giving lectures over the past year or so discussing chronic hand eczema. And we obviously have a new drug on the market that we'll talk about soon, but I want to get into why is it relevant? Why is it so important for us to have this conversation?
I think chronic hand eczema is a debilitating disease state that we see a lot of in dermatology. And I think it's incredibly more prevalent than we give it credit for. The lifetime prevalence is almost 15%. And we're really seeing a lot of this. It's 10% in a year of adult life. So it's something that's really common in women, has a lot of occupational exposure. So I really feel for women who are out in the workforce and then have an occupational exposure to something that limits their productivity or their possibility to make money. Also has a lot to do with domestic exposures, and moderate to severe disease affects a third of patients that we see. So I feel really passionate about being able to treat something that we see a lot of in the office and give people back good quality of life.
So let's kind of talk about, you mentioned some occupational exposure. So what are some of the most common professions that you run into clinically where you're seeing a lot of this? Obviously, I've experienced hand eczema myself because we're constantly washing, at least you're supposed to, washing and using hand sanitizer after patient exposure. And so after doing that for 8 hours a day, obviously, healthcare providers will develop this. But what other professions and jobs are you noticing this in?
I see a ton of this in preschool teachers. I see a lot of this in chefs and food service workers. A lot of people that work in metal industries have a lot of exposure to different metals that can have reactions to it. Um, I see it in just nannies and women. If stay-at-home moms get
Yep.
a lot of hand eczema, I think we all know, any moms that are out there listening know that you wash your hands in bottles and pump parts 5 million times a day, and it's already hard enough to live without sleep, but then to live with your hands falling apart at the same time, I think is a big thing that can affect you both professionally and personally.
Absolutely. So let's kind of talk about some of the subtypes because I think for a long time we would just call it hand eczema, right? Or maybe we'd kind of categorize it as deshydrosis if we saw the blisters, but there are specific subtypes when it comes to chronic hand eczema. Can you go over what those subtypes are?
Sure. So there are three main big subtypes that we really talk about. Irritant contact dermatitis is the most common subtype, and this is a prolonged, repeated exposure to an irritant. There's no relevant true contact allergen that we identify here, but we see that erythema, the scaling, the fissures, and we see it from cumulative exposure to water, detergents, solvents, and it just causes that barrier disruption that we see on those patients.
Right? This can be just normal water exposure that can cause irritant contact, correct?
100%.
Okay.
So this most likely isn't an allergen. This is more that repeat exposure to something that's really breaking down that barrier and the barrier disruption.
Right.
This is the most common subtype. So we see a lot of irritant. It's around 40% of chronic hand eczemas have an irritant component to it.
One thing I wanted to mention with the irritant contact dermatitis that I've seen a lot of in clinic is patients will come in with a rash under their wedding band or their ring. And a lot of the times they think it's an allergy to that metal that they're wearing, that it's a gold allergy or to, whatever metal their ring is made of, but it actually ends up being irritant contact due to water and soap exposure under that ring, right? Have you seen quite a bit of that?
Absolutely. Absolutely. I see a ton of it in clinic. I always feel for the women that get their new rings and they're so excited about them and then they come in and they're panicked that they're allergic
Yep.
to their ring and you just tell them that after they wash their hands, make sure they lift it up and dry underneath it and get any of
Yep.
that soap or solvent out from underneath it.
Exactly. Right. What else? What are some other subtypes?
So there's allergic hand dermatitis, and that one is really due to that relevant contact allergen. This is when patch testing becomes really important. This is the part of hand eczema that we really do see that you are coming in contact with an allergen, and it's the allergen exposure that's causing that rash on the hands. And then I also want to talk about atopic hand eczema. So this we see, in our patients that have atopic dermatitis other places on their body. So when you're looking at hands, sometimes it's important to really ask your patients, do you have any atopic dermatitis or eczema anywhere else on your body? It can be a good clinical clue if they have atopic hand eczema and if that's a component of their disease state. Really common on the palmar surfaces. Asking that medical history is really, really important, but it does predispose these patients to that irritant contact dermatitis because they have that disrupted barrier. But what I really want to talk about is that most cases of chronic hand eczema have more than one of these subtypes. So, taking a really good history from a patient and not just trying to put chronic hand eczema in a box of this is irritant or this is allergic or this is atopic is so important because so many times the patients have more than one subtype. It's more than 50% of cases we're seeing overlapping subtypes. So, I know I feel this way in clinic. When I figure out what's wrong with somebody, it's like that light bulb goes off, like,
Right.
oh, I can fix this person because I know exactly what's wrong with them. And chronic hand eczema is a little bit different because you might know that they're allergic to something, but there may be an atopic component underneath there or an irritant component. So, really diving deep into what do they do for work? What are they exposed to? Are they using the correct emollients on their hands? What are they coming in contact with? These are all really, really important questions and the history, like they tell us in school how important the history is, the history here is so important to diagnosis.
Right. And I think that makes it very challenging when we're dealing with chronic hand eczema because it's not just one thing. And I've had a few patients over the years where we found a positive allergen, one of the more common ones being MI and MCI, methyl isothiazolinone. And the patient will remove this product from their skincare, and oftentimes they'll still have a little bit of rash remaining. And so we have to remember that there is that irritant dermatitis component of it. There could be other forms of hand eczema going on, but it does make it a little bit more difficult to treat. And at least for me, how do you decide when you're going to do that investigation? Like, when is patch testing necessary? Are we going to just focus on topical therapy? Are we addressing it with systemic therapy if it's atopic? But how do you decide when you kind of pull the plug on therapies and investigating, right?
It's a great question. So Europe and the United States have different guidelines as to when they patch test and when we don't. The Europeans think that we should patch test for everybody and figure out if there is a true contact allergen that the patients are coming in contact with. We don't do the same in the United States. We really use patch testing if we think that there is a known allergen that the patient is coming in contact with. And that's for multiple reasons. One is we don't want to delay treatment for the patient. The biggest thing is we want the patient to get better. At the end of the day, just like you said, you can figure out an allergen for a patient, but that may not actually change the course of their disease state. So we want to make sure that we get treatment for the patients faster than we can necessarily get patch testing results. And some of the patch tests that we do in our office don't have all of the allergens that a patient could come in contact with. And getting into the offices that have those extensive patch tests can take months or even years. So we like to treat in the United States before we have all of the patch test results back. Europeans look at it a little bit differently that they want to know the full picture before they give a specific treatment. So while I do want to know all of the pieces or as many pieces as I can know, I agree with the United States guidelines that we want to treat somebody and get their symptoms better. If they really have bad itching and pain associated with their disease state and it's limiting their productivity or their personal life, I want to get them treatment as soon as possible. So it doesn't necessarily matter to me if the patch test results are in before I start treating somebody.
Absolutely. And speaking of patch testing, I think I mentioned already MI and MCI being a common allergen. I think it's actually decreasing in its frequency. But are there other allergens that you run into for patients that truly do have allergic contact dermatitis?
I see a lot of nickel. I see a good amount of fragrance. I think fragrance is a really big one in the United States that people don't realize how much fragrance is in things. So, I do see a lot of fragrance. I do see formaldehyde. I think that's a common one as well. Um, those are the big ones that I see. But, I see gold frequently when I patch test patients. That's a hard one for women. They really don't want to get rid of their gold jewelry.
Right.
Or occasionally you have that male patient that's like, I like, my wife's going to get mad at me if I can't wear my ring. And I'm like, well, yeah, we can dip it in platinum or do something different. But they, I think metals are a very, very common allergen that I see in practice.
And
Do you
so
agree?
I definitely agree. To that point, as we're kind of evaluating that patient, maybe it's not time to do patch testing quite yet, or we're just seeing them for the first time. Are there certain clues that kind of give you an idea of what they're actually dealing with? Like if you see blisters or, like the small vesicles, is that more common with allergic contact versus irritant? If you're seeing fingertip involvement, are there certain areas that seem to kind of prime you to believe it's a certain diagnosis, or what are your thoughts on that?
Sometimes yes and sometimes no. Sometimes I think it can lead you astray. And then other times I really do think that it really can give you good clinical clues. That hyperkeratotic hand eczema, that really bad thickening on the hands, interestingly, is really, really related to smoking and more common in men.
Interesting. I have never heard that before. And I've
Yeah,
seen
so
it as I think about it, but I didn't know there was a correlation there. Interesting.
there's a correlation with smoking and hyperkeratotic hand eczema. So I know we all learned in school that telling patients stopping smoking is the number one thing they can do for their health.
Right.
But I always stress to people, like, this is a point when I really use that in clinic. And I'm like, you're really concerned about your hands, and your primary reason for coming to see me today is because of your hands. And I actually know there's a correlation between smoking and that really thickened skin on your hands. And sometimes that really resonates with people. If it's
Right.
really affecting their productivity and their personal life, it can really, really affect them. And they're actually willing to consider decreasing their smoking. When I see really bad fingertips or vesicular hand eczema, I do think irritant contact. That tends to be the first thing that comes to my head. That really dry red scaling tends to be more irritant, but sometimes atopic underneath it. Sometimes it's hard to tell. I mean, sometimes there are so many overlapping subtypes that it's really, really hard to tell exactly what's going on. And I'm thankful because some of our treatment options have made it that it doesn't necessarily make the biggest difference to me exactly what's causing their diagnosis, because now I have good things that I can treat them with.
Absolutely. So let's kind of make that transition now into treatment. So for any sort of inflammatory dermatitis, eczema, my first conversation with the patient's always going to be just what can we do as far as hand care, skin care, preventative management. So what are some of your favorite tips as far as telling patients how do we reduce the risk of this rash in the first place?
I think the biggest thing is really having that conversation with them that, like, if they're frequently coming in contact with water, frequently coming in contact with something that we do think is an irritant or an allergen that they're coming in contact with, really creating a good barrier for them. So, people that do a lot of water work, or women who have a lot of domestic exposure to water, or healthcare workers, or women who are washing a ton of dishes, or preschool teachers, I really have a long conversation about how important gloves can be to really create a good barrier. I like gloves that have a white cotton inside. That's a really important thing to me. I like to tell women to use those dish gloves. I call them old granny dish gloves that come up to your shoulder, like
Those are
your
the
elbows.
best. The best.
They're the best,
Yes.
and they really protect you from that water damage.
Yep.
I love to tell young moms who are washing, like, parts to their pumps and washing tons of bottles, that putting those on is gonna make a big difference to create a good, like, true physical barrier for them before they get that skin breakdown. Same with people who just, like, some people love washing dishes, or people that work in a restaurant, like, they just have that consistent exposure. So I talk about true barriers that we can create to really protect the hands. But then on top of that, making sure they're using the right soaps and the right lotions. Really, really harsh soaps, obviously, we know really break down the skin barrier. And using appropriate emollients make a huge difference to help rebuild that barrier on the hand. So I always talk about it doesn't matter what I give you as a treatment option. These things are the mainstays of treatment. So creating a real good barrier and using the really good emollients and less harsh soaps on a regular basis make the biggest difference in this diagnosis.
I agree 100%. A lot of the times I actually try to paint the picture like as we're walking through their house. Like when you're washing in the kitchen, washing dishes, I don't want you to touch a fork in the sink without putting your gloves on. Like I really emphasize that part for patients. And a lot of the times hand soaps, people do forget about that. And I have some patients where there's a Bath and Body Works hand soap in every bathroom in their household, foaming, full of fragrance, full of dyes. And so I make sure that I mention that too, that I think people underestimate again how much they're washing their hands and all the exposures they're getting throughout the day. So, hard to control when you're outside of your home sometimes, but in your house, you have full control over what you can do there.
Absolutely. But you just brought up a great point. It's not just the soaps, it's also the hand sanitizers.
Hmm.
And that's a big thing that I stress to people. Post COVID, people love hand sanitizer. It is such a big thing post COVID. People can't walk around anywhere without having 900 squirts of hand sanitizer. And I just stress to patients, and patients that have really, really bad hand eczema hate hand sanitizer because it burns their hands.
Right.
But some of them get to that point that they have really bad hand eczema because of the chronic use of hand sanitizer. I know I switched practices recently and we had a different hand sanitizer, and my hands started to flare because my hands weren't used to the specific hand sanitizer that we were using in our office. So, like, and that this as healthcare providers, we're either washing our hands or using hand sanitizer, I would say a minimum of 75 to 80 times a day.
Agreed.
So, it is that consistent exposure. So, telling people it's important that we wash our hands and that we're clean, but we don't necessarily need to overuse or overwash or over hand sanitize is a
Yeah.
really important thing.
My nurse patients will give me the craziest look when I tell them to stop washing as frequently, which I know it sounds insane, but that's just the reality of it. So I'm like, if you have to wear gloves more frequently, then so be it when you're having patient encounters, but you really have got to find a way to stop washing as frequently. And when you can't, if you have to wash your hands, obviously moisturize immediately after as often as you possibly can. Let's go into some treatment options. So, what are your kind of top things that you're doing topically? And then when are we looking into systemic therapies? What's your approach to management?
So, my biggest approach to management, I think, still the mainstay of treatment, and the guidelines really still guide this way that you start with topical steroid. And I think they really do quickly eliminate that inflammation in the hands. Obviously, still talking about, using good soaps and good lotions, but topical steroids and high potency topical steroids in the ointment form most commonly is where we start with treatment for chronic hand eczema. Um, and then sometimes I'll use those non-steroidals that are on the market as well, and I'll use the tacrolimus or pimecrolimus to try to move away from topical steroid. I think a lot of us have become really good steroid stewards that we use them initially to get things under control, and then we move to non-steroidals to try to get better control. So I do use non-steroidals on a regular basis if I can get things under control because I think they're safe for long-term use. And then in the last year, we now have the only FDA approved treatment for chronic hand eczema. It's called delgocitinib. And it is approved for moderate to severe hand eczema. It's a twice a day pan JAK inhibitor. And I've had great success with it. I think it works incredibly well. Non-steroidal, safe to use long term, has great efficacy. I will tell you the efficacy I see in clinic is even more than their clinical studies show. Their guidelines for the clinical study were very stringent, so you needed to have really basically perfectly clear hands to be considered a success in their study. So clinically I'm seeing great success with the drug. I had a really big win with a preschool teacher in the office a few weeks ago. She came in and had horrible hand eczema from washing her hands. She had switched from one preschool to another preschool, and whatever hand sanitizer or soap they were using was so harsh on her hands. And she came in and they were so fissured. They just looked painful.
Mm,
And I gave her delgocitinib, and I was lucky enough to see her back a week later. She came in because she had a mole that she didn't recognize, and I got to see it, but I got to see her hands a week after a week of using delgocitinib, and she told me, she was like, "My hands don't hurt when I wash them anymore." And this was 7 days after I gave her the drug, and it was just it was a win as a provider, but also a win as a person to watch somebody be able to do what they do as their profession and what they love without suffering through every hand wash.
And I think it's crazy that, I mean, it was only a few years ago that we really couldn't accomplish that without using either a potent topical steroid or even systemic steroids sometimes. So the fact that you were able to do it not only with just a topical that's non-steroidal, but within 7 days is incredible. And
Absolutely.
another thing I'll mention with Delga, which you may have touched on this already, but the fact that it's a pan-JAK, but it has no black box warning, right?
Yes, no black box warning, pan-JAK. I think the real big thing that I want to point out with pan-JAK is I think the reason that it works so well for patients with chronic hand eczema is like we talked about, there are these overlapping subtypes of hand eczema. And using a pan-JAK inhibitor, we can attack all of those subtypes from all of the different angles, which is why I think this drug is so successful to treat chronic hand eczema.
Excellent. So, as we kind of close things out, Lisa, just wanted to go over a few kind of key points. Number one is obviously we know that chronic hand eczema, extremely common, can be very debilitating for patients, and it's multifactorial, right? So we're not just seeing it being caused by one specific thing. It could be lots of things in that patient's livelihood that are causing it. And I've had patients where oftentimes it's between let's get this hand eczema under control, or otherwise you're going to have to quit your job. Like it really can be very much debilitating and life changing for patients.
I
We
think that's a regular
yeah,
conversation we have as providers with
absolutely.
our patients.
Yeah. And then as far as, diagnosis goes, again, if we can, we get to the bottom of it with patch testing. If not, we still can intervene with therapies. And obviously, preventing the hand eczema is just as important as treating it. And so we can introduce some measures at home to help reduce the risk of it. But any other takeaways? Question for you, actually. How do you manage the fissures? Those are really tough sometimes. Do you have any special tricks for that?
I've been using more Delgo with the fissures or Delgocitinib with the fissures and having good luck. But I wish I had great answers for how you treat the fissures, but I really think getting rid of the exposure to things that have a lot of alcohol in them or a lot of different products in them that may be, affecting the patient make a big difference to the fissures. But so far, really just trying to get the inflammation under control has made the biggest difference for my patients.
Excellent. Any other takeaways, any other key points you want to share with us before we close things out?
I think it's an exciting time for chronic hand eczema. I think there's more and more research that's coming out. I think this is an under-recognized disease state in dermatology, and I think it's an exciting time to be a derm provider, to be able to have new treatments and new opportunities to make better lives for our patients, which is why we all practice medicine to begin with.
Thank you so much, Lisa. I knew it was going to be a pleasure having you on the podcast, and you did not disappoint. I'd love to have you back again, and thanks for doing this today.
Thank you so much. It's an honor to be here. I'm so happy to be part of this.
Thanks for tuning in to SkinSync. Don't forget to subscribe to SkinSync on Spotify or Apple Podcasts so you never miss an episode. To explore more of Elevate's educational and career resources, visit elevate-derm.com. Please note, this podcast is for informational purposes only and not a substitute for professional medical advice. Always consult a licensed healthcare provider before making medical decisions. Clinicians must rely on their own judgment and training in all patient care situations.